the Coppi doesn't need much of an introduction. I think everyone knows him just by the virtue of him being the president of our association, EUPSA, which is these webinars are under the auspices of EUPSA. But just to do a very brief summary of his very bright career, he was born in Italy and near Padua, where in fact he did medical school and also his initial training in pediatric surgery. Did obtain his PhD also from Padua, but he spent quite a significant amount of time in Boston, at Harvard University, working with Anthony Atala, and that collaboration led to the seminal paper where he in fact described for the first time the presence of stem cells in the amniotic fluid. And then Paolo was appointed by Great Street, if I remember right, in 2006 as a consultant pediatric surgeon, and he's been there since then. He's also an honorary professor at the Katholieke Universiteit in Leuven, Belgium, and in fact, in the last few years, his interest in regenerative medicine and in utero therapies have pushed him also beyond the boundaries of neonatal and pediatric surgery, and is also performing fetal surgery procedures. And the combination of his scientific and clinical interests have led him to, in fact, gain an honor that I don't think anyone in pediatric surgery has ever had, which is to be listed in the Time 100 Health from Time magazine. Definitely an incredible honor. Of course, he's incredibly well published with over 80 of H-index and more than 25,000 citations. He's published in The Lancet, Nature, Blood, and Science. He's also an editor, senior editor for Stem Cell Translational Medicine. I could go on and we can take up the whole time of the webinar and further embarrass Paolo on these screens, but then I think it wouldn't be that good use of time. So Paolo, without further ado, really excited to hear about what you can tell us about your experience to manage Aortopexy at Great Street.
Thank you, Augusto. It's a bit difficult to follow after this introduction. You certainly know how to introduce people, but thank you very much. It's really an honor and a privilege to be here and be invited to talk in this webinar, which has been very successful. And thank you, Martin, for being here, and also being here with a friend, Stefaan, to share our experience, which is divided by a channel, but it's very similar in many aspects. So first, I want to point out that you cannot do that alone, in the sense that it's so important to be part of a team. And actually in the team is where all the decisions are made. And I hope I will make it clear that it's thanks to the team you can decide the optimal treatment for malacia. And I have no disclosure for this talk. And I think we have to define first what malacia is. That is the dynamic collapse of a large airway. So the dynamic collapse means that you have to have a dynamic study to describe that, but it can be due to various reasons. You can have cartilage weakness, a compression, or a posterior more weakness. And I think we will define this more and more during the talk. The symptoms can vary. It can be from asymptomatic to go to respiratory stress. And in fact, the treatment should be tailored around the patient that you are evaluating. And that's very important for all the treatment pathway that we will describe. And the incidence is established to be 1 in 2,000, but it varies according to different literature. And of course, it varies because tracheomalacia, or Malaysia in general, doesn't represent one disease, but represent more than one disease that is associated or not to other factors. But the classification, make it clear by the European Respiratory Society, define the primary Malaysia as the intrinsic abnormalities of the airway or cartilage. And the secondary is where the cartilage is actually normal, but you can develop abnormal to external pressure. And the management is still not clear. Certainly, the investigations are complex, and certainly, at least you should have an MLB, and you should have a bronchoscopy and bronchogram. We combine the two together at Great Ormond Street Hospital, and you should have CT imaging. Particularly nowadays, you should have a 3D reconstruction of CT or MRI that will tell you more. But certainly, as I say before, the dynamic of the diagnosis means that the test should be dynamic, and the bronchography and the MLB, and combined with the bronchogram can help on this. OCT is also a technique that is coming up more and more, and we found it very useful because it gives you really the composition of the cartilage. So you can go down and show really how the cartilage strength of the trachea is, and decide therefore the best treatment for the child. So when we talk about options, of course we have to remember that there's no randomized controlled trial in this field, and so the management of Malaysia can go in different directions depending on what is your experience at your center. Many times, children with severe Malaysia get straight away a tracheostomy. And this is the experience in various centers. We believe that Aortopexy, it's certainly the treatment of first option for these children with their severe Malaysia. And there are other treatments that are here listed. But essentially, what I want to talk to you today is the Aortopexy. So the choice of the Aortopexy can be either open or thoracoscopic. In the open, we start with a different approach, and depending on the experience that is at your center, you can start with a thoracotomy and in the second space on the left side, get straight to the place where you need to be. You can have a limited sternotomy or a suprasternal incision, and all these three approaches should get you to the place where you need to be, which is around the arch of the aorta. To get to that space, of course, you have to remove the thymus. It depends on which age you're adding in for the Aortopexy, but certainly in the age where this is mostly done in the first year of life, the thymus can be quite big. And actually is one of the principles that was designed at the beginning when the Aortopexy was described, was the fact that the space occupied by the thymus can be occupied by the aorta, so you can pull the aorta in that space. When you do an open thoracotomy, you generally remove the thymus. I will say that when we do thoracoscopic, we nowadays mobilize the thymus more than removing. Then you need to define the anatomy, of course, and in order to get to the stitches where you want to go, you have to open the pericardium. So you really get to the base of the aorta, and you have to stitch at least put 3 stitches, and you need to put it up to the origin of the right innominate artery. By doing that, you create a plane. So with the 3 stitches, I mean, this is math, it's not surgery. 3 stitches define a plane. So you need at least 3 stitches to define the plane where you want to elevate the aorta. And when you fix those stitches, you put the stitches then through the sternum. This is the sternotomy. After closing, you close the stitches there. We would use pledgets because the pledgets will fix the stitch and will avoid the migration of the stitch through the bone. So at the beginning, certainly on my experience thoracoscopic, I was not using the pledget, but then some of those were recur because the stitch moved down into the sternum, and with the pledget, certainly, which is routinely used open, we could get the stitch more stable. This is just an open approach, which the stitches go through the aorta, and you see the stitch also on the pericardium, and then those stitches will be pulled through to the sternum to fix. Various variation have been described, putting pledgets on the aorta, putting patch of pericardium, of Dacron to hold those stitches in place in the aorta. Those variations can be used, but essentially the principle is to put these stitches in the arch up to the nominate and pull those through the sternum. And then this the open approach. And in order to do that, you have to look at what you're doing. So immediately pre-op, as part of the operation, we would do a bronchoscopy, which give us the baseline where we are doing. And then during the operation, you will use a flexible through the tube. So you can go through the tube with a fish mouth tube. You can put your flexible and observe while the stitch are pulled the trachea opening. And that's very important because you need to see what is happening there. So a few years ago, under the guidance of Professor Martin Elliott, who has led for many times and has really created the tracheal team at Gosh, is now retired, we look at our first 100 aortopexy. And we have to appreciate that these children not always survive. And the population that we're talking about is quite severe. Now, when we look at our experience between 2006 and 2010, the survival was 75%. That improved in the series between 11 and 2016. And to 95%. And mainly the improvement is the fact that the cardiac outcome of congenital cardiac disease improved massively during that time, and that's why it improved. And in fact, we have to remember that in tracheomalacia, there's certainly an association with cardiac anomalies, which are frequently associated. These are just some of the cardiac anomalies that we found in our experience, and the association is very clearly linked. When we talk about the freedom from reintervention, was very important because that correlates strictly to the location of the malacia. So the tracheomalacia are known to do better with a freedom from operation that really stabilized the early recurrence right after surgery, and then there's a good outcome for months after the surgery. And while the tracheobronchomalacia, so involving the trachea and the bronchi, are worse effect, worse in terms of outcome. But the one doing the worst, which is quite understandable, is the bronchomalacia itself, because they tend to do bad since early after the surgery. The outcome also and the survival depend on the association as discussed. So for group 1, that would be the isolated malacia, and group 2 with non-cardiac vascular compression and vascular ring and pectus excavatum, that will do generally well, while the one with major comorbidity, so major cardiac, their survival is the one that is the worst of the group. And when done a multi-variable regression outcome of those patients, the one that die, of course, were the one that had a preoperative ventilation, so they were in ICU essentially for a long time intubated. But the reintervention was mainly due to the involvement of the bronchi. So tracheobronchi and bronchomalacia are the one doing the worst. Then, of course, we look around and there were people proposing to do the same operation thoracoscopic. And actually, it's very nice to have the talk tonight with Stefaan, because at his center is the center that really promoted through Van der Zee and all these group the use of the thoracoscopic aortopexy. So the way we do nowadays, the thoracoscopic approach is with 3-port on the left side. The patient is supine, but there's a slightly elevation on the left side with the 3-port position as in the figure. And we have described the technique. And essentially, here is a section of what you will see. And when you enter the left side, you have to remove part of the thymus or mobilize it nowadays. So the 3-port will be directed towards that direction. And then after putting the 3 stitches on the aorta is pulled towards the sternum. So the principle is the same. So this is what you would see initially. You would see the thymus in front of you. The pulmonary artery is the first vessel that you see. So at the beginning, when I was doing the first one, I was worried of not seeing the aorta, but the aorta is just slightly on the other side. So you have to go over the pulmonary arteries to see the aorta. And then when you do that, you remove a bit of the thymus and you start stitching, as you see here in the aorta. So the stitches are really needs to be a 2-0 or 3-0 prolong, strong stitch, because they need to go through the sternum. And then you retrieve it with the endoclose or any other instrument through the sternum. So this is the first stitch, just to see how you can pull the aorta, and then the 3 stitches, and then you pull it and you attaches to the sternum. So these are the 3 stitches in sequence from the lower in the left side of the screen to the upper towards the innominate on the right side. So this was the initial experience in which we published about 20 patients. And in this experience, we saw that they were all small baby. There were very little cardiac anomalies and no severe cardiac anomalies. And the site of the malacia was mid to distal trachea in the majority. And in fact, they did intraoperatively quite well for the initial experience. We had only one that required a chest tube. Normally, we don't leave any chest tube, but one bleeding of the 2 that happened intraoperatively was a bit prolonged, so we worried and left the chest drain. Otherwise, you don't need to leave a chest drain. What we learned in the initial experience, that you need to put them in the ICU for a few hours. So don't try to extubate them right after surgery, because you will have to reoperate. And in this one, there was 2 patients that require a redo, and at that time, because it was initial appearance, a redo, we would do it as open aortopexy. The one that did the worst and end up having further treatment, as not a surprise, was the tracheobronchomalacia. So we more recently reviewed the experience of combining together the open and the thoracoscopic one, and these were the number 169, the most recent number, with the median of follow-up or almost 9 years. So to summarize, it's not a surprise that the one that received more thoracoscopic, where involving only tracheomalacia, and that's very important to have patient selections. And the one having a bronchial involvement, we're mainly having open surgery. When we consider the primary airway malacia, those were the ones that received thoracoscopic and also post-esophageal atresia. We're receiving thoracoscopic, while sternal vascular compression and etc. did need were selected to have an open surgery. In terms of complications, we didn't see a huge amount of difference between the open and thoracoscopic. But when we look at the patient selection, of course, tough, we're mainly having thoracoscopic approach, vascular ring, we're all having open approach or vascular compression. So this is a multidisciplinary management which led to this selection of the open versus thoracoscopic with a time of extubation that is slightly longer on the open, but they have different comorbidity. So in conclusion, at our center, the Aortopexy is the choice procedure for malacia. The careful patient selection is vital because not all require the same treatment. And the bronchomalacia is the most risk factor for persistent symptoms. There's a group of patients, and that lead to the next talk, in which there's a posterior prolapse in esophageal atresia, for example. So is that the space for posterior tracheopexy? Well, I'll leave you to this flow chart that is what we use. So patient that would go to a thoracoscopic approach is essentially the esophageal atresia patient and a selected patient with innominate artery, or when there's no vascular compression beyond the ascending aorta. The rest will go at our center at open aortopexy. I want to reemphasize the role of the team and thank you again for your attention.
Okay, so the second speaker of tonight is Dr. Stefaan Tytgat. He is a well-known surgeon for esophageal surgery. He serves as the head of department of pediatric surgery at the Children's Hospital in Utrecht, the Netherlands. He has undergone surgical training in Amsterdam and then specialized with giants in the field like Klaas Baks and David van der Zee. And this center in Utrecht has a long-standing history of MIS for the chest and the abdomen. And I'm sure a lot of you know the work that has been come from this center. Dr. Tytgat has over 280 procedures in that center and with his team over the past 20 years. And yeah, this is what they do really and focus on. And this center developed new treatment strategies, including thoracoscopic external traction technique, the Fokker technique, and defined that and redefined that and reshaped that in a way that can be performed safely. And they're also recently have developed over the last year the primary thoracoscopic posterior tracheopexy, also in primary cases for TEF and in patients with severe tracheomalacia. Dr. Tytgat is also the workstream leader of ERNICA for the workstream of esophageal diseases. And that is why also this webinar today is a EUPSA ERNICA webinar, a joint endeavor. And that also tells us, if we look at the high number of delegates who logged on tonight, that when EUPSA and ERNICA go together, we are the most successful also when it comes to education and teaching. So Stefaan, it's a great honor for us to have you with us tonight. And we are looking forward on your talk about tracheomalacia.
Thank you, Martin. I'm honored to be here and very thankful for also choosing this very important topic. I will talk about posterior tracheopexy and also the primary posterior tracheopexy performed during esophageal atresia repair. Symptoms of children with tracheomalacia can be very difficult to understand. But these children suffer while breathing. They need to breathe shallowly, so very lightly, in order to have an open airway. And once they put too much stress on it, their airway collapses and they can't exhale until they start breathing shallowly again, so they can start drinking again. Now, in previous years, some time ago, it was expected that only 1/3 of the patients might have tracheomalacia. But more recent publications had over 80% of the children do have it. And if you consider atresia, foregut anomaly, then of course you have an esophagus and an airway forming from that foregut. You might also have deformities of the trachea, and I think it's part of the same spectrum of diseases. There's a wide variety of symptoms in these children. They have coughing, wheezing, difficulties breathing, and also feeding, and eventually blue spells or altus or bruise. I don't really like those definitions, but abbreviations, but maybe we should think of a new term when it's related to esophageal atresia. And more recently, more and more reports tell that these children after esophageal atresia repair suffer from recurrent severe respiratory tract infections and eventually leading to prolonged pulmonary loss. If you look at bronchoscopies, and I will skip through them a little bit, but you can see if children who with airways which can completely collapse, you can imagine how difficult it is for them to breathe and to clear their airways and to have a normal functioning lungs down the line. This is one patient, and if you look at another patient, you'll see similarly that the airway can close completely, all high up in the airway, all the way down, and it's mainly the posterior side which can intrude into the lumen. It's the flaccidity of the posterior wall, together with the flatness of the bronchial arches, and the posterior wall is too broad, more than 1/3 in these children. Now, as Paolo indicated, Aortopexy addresses the anterior side of the trachea, and we don't remove the thymus, we push it away to the right side if we do a thoracoscopic Aortopexy, and then by moving the aorta ventrally, you give more room for the trachea to on the frontal side, but it doesn't really address the posterior side. As Paolo said, there are no randomized controlled trials for neither, nothing will be discussed today, but yeah, it's about 80% effective, and it's not without complication and even mortality related to the surgery. And of course, there's a recurrence rate in thoracoscopic, in aortopexy as well. So I used to perform here also in Utrecht, and I learned from Dave van der Zee and Klaas Baks. Yeah, eventually, since introduction also from Boston, where the posterior tracheopexy was introduced, and that gained our attention. The principle is different. You move the esophagus towards the right side, and you hitch the posterior tracheal wall towards the anterior spinal ligament. So you can effectively prevent posterior collapse or intrusion of the posterior wall into the lumen. And furthermore, you also stabilize the posterior wall, which might have an effect on the effectiveness of coughing of these children, and also mucus production and transport. When you're there, you can also address complications of the previous EA repair, like a remnant of the TEF, like a tracheal diverticulum, or recurrent esophageal fistula. But if the child had previous EA repair, even if done extrapleurally, it can be very difficult to access the right thoracic cavity again. The lungs are adhesed. The anatomy is difficult to recognize, and it can take hours to get this picture here. Now, if you look carefully, you can see this is the posterior side of the tracheal wall. You can see how flaccid it is, and it can bulge up, but it can also go into the lumen. So this is where you're going to place your stitches. This is the esophagus being pulled towards the right. This is the spine on the back wall. Placing the sutures only on the back wall, but not into the lumen, and then lifting it up. You can see how much flaccidity there is, and you will do this also under bronchoscopic guidance. And there's another movie of that. So there's this one. Oh, I skipped a little bit. Also here you see lots of damage to the lungs, and also it's very difficult to take down or to go back into the wall between the airway and the esophagus on top here. And by lifting the esophagus, and we try to find a plane, you're going to see that we end up, you see also some air leakage, we end up perforating the trachea. So going back in after previous esophageal atresia repair is very difficult. Now we suture it down, and we end up using a stapler to close it down. So you can skip a little bit. And then, yeah, you can see the staples here in the back wall, and then we hitch the posterior wall eventually towards the spine in this case, and the child recovered well from it. So with this in mind, we decided to start with the primary posterior tracheopexy during thoracoscopic EA repair, because we didn't want to go back in, and we didn't want complications of the tracheomalacia for these children. And basically the procedure is well, like a normal type C thoracoscopic EA repair. You take down a TE fistula, and after that you place the sutures 1 to 3 in the posterior wall towards the anterior ligament, longitudinal spinal ligament, and then you anastomose both ends. So in these children, we start off with bronchoscopy. I will go through this video quite quickly. You take down the TE fistula, it's closed. Nowadays, we use non-absorbable sutures here. The proximal pouch is dissected free from the thoracic inlet. And once you've done that, you can expose the posterior wall of the trachea. Always we will look to see if we did well in location and that we didn't enter the lumen. So this is the bronchoscope, which is brought in to check the sutures. And then we change with the needle hole towards the left hand to place the sutures through the spinal ligament on the left side. Sutures are placed, and intercorporal, we don't use non-absorbable sutures here. I'll skip a little bit. Care should be taken to leave enough space for the proximal esophagus, because it's being pushed towards the thoracic inlet. So there's enough space there that you don't close down the thoracic inlet and you nick down the esophagus. So bronchoscopic guidance, very important. The needle enters the lumen here. Just by chance, we took a video of it. And then you just take the wall, but don't enter the lumen. Otherwise, you will get a granuloma. Okay, once that is done, the anastomosis is laid. Here, usually nowadays, we leave the azygos vein intact and just leave the esophagus in its own normal position, actually. And the anastomosis is completed. So this is actually the bronchoscopy of the first patient in which we performed the posterior tracheopexy. And this is the TE fistula you see there. In the distance, you see the bifurcation. And once you pull back the rigid bronchoscope, you can see it stents the posterior wall. And while pulling it back, the posterior wall intrudes the lumen. And yeah, and that was quite severe. So in this patient, we decided, well, let's try to perform the tracheopexy. Now we're here already, instead of having to come back here in another 4 weeks with a child with respiratory problems. The child recovered well after surgery, and 4 weeks later, we repeated the bronchoscopy because the child had an esophageal stenosis. And this is the same child, same position. And you see that the posterior wall has no ability to protrude in the lumen anymore. It's way more stable. And the child actually had no respiratory problems whatsoever. And also in follow-up, it didn't have any infections or respiratory incidents. That led to a trial, like a cohort trial we did. We looked at, since we introduced the primary posterior tracheopexy thoracoscopically, so we took a cohort of 2017 to 2019, 14 patients of the 38 patients had a primary posterior tracheopexy, and 8 of them had moderate, so we have like a division in 3 parts, like 1/3, 1/3, 1/3. So moderate is the middle third, or severe, it's like more than 2/3 collapse. And 2 patients were included who, once we took down the TE fistula during thoracoscopy, we found that the posterior membrane became way more flaccid. So we think taking down the fistula has an effect on the flaccidity of the posterior wall, and also maybe makes the preoperative scoring of the tracheomalacia on the bronchoscopy less reliable. And one of our conclusion was that, if we look at the cohort, we saw a significant decrease in respiratory tract infections in our children when we compared them to 2 years prior to introduction of the posterior tracheopexy. Also, maybe blue spells and bruise, but that was not significant, and also the groups were not large enough to see that. Since then, we have only performed posterior tracheopexy. In the last 130 patients, 31%, like 41 patients, had a primary posterior tracheopexy in our center. And if you look at it, very interestingly, none of the type A or type B to true long gaps had a tracheopexy. We have abandoned performing aortopexies, and we have never needed it anymore since 2014. And prior to that, it was our way to go. And one of the children had a redo posterior tracheopexy in our series. To come to the conclusions, I think posterior tracheopexy is very promising for these children. It's a kind of new technique from the last 7 or 8 years. It might prevent secondary complex surgery like aortopexy, or performing a repeat thoracoscopy from the right, or thoracotomy. It might prevent life-threatening respiratory symptoms in these children, and we found a significant reduction in upper airway infections in these children. So that's now our preferred approach in these patients. We like to perform preventive measures. It's not very difficult. You're there already. Placing the sutures, it's like 6 minutes per suture, 1 or 2. So it doesn't add too much to the operation time, and you're there anyway. So with our protocol, there's hardly any need for aortopexies anymore. And we would only consider that if there's an anatomical structure pressing down on it, like Paolo said already. So we perform CT scans in these children to see if there's an anatomical problem. Then aortopexy might be considered, but would not be our first choice anymore. In recent years, this is like I took it from PubMed, and I looked for posterior tracheopexy, and you can see since the introduction, it's like increasing in numbers. and over 50 publications are already there in the pediatric surgical population. And almost all conclude that there's a significant reduction in respiratory morbidity. One of the nicest recent publications from Boston again, with very impressive results in the cohort of children which had a preventive posterior tracheopexy. There's, of course, and maybe we can discuss this today as well, who needs it? Is it more than 2/3 intrusion of the posterior wall? Or does it depend on what you see after taking down a TE fistula? Many questions which we don't have, but I'm very honored and proud to say that now this year we started the prospective randomized control trial, which is very rare, I think, in pediatric surgery, but together with also London, Rotterdam, and Stockholm, and it's led by Maud Lindeboom from our team. And it's called the Portrait trial, which we will randomize between two groups with or without posterior tracheopexy. So we will have to wait for those results, but I'm very happy to be part of that as well. I want to thank everybody in our team. This is also the surgical team, and I'm happy that David's on there as well. He retired some years ago already, but especially in difficult cases, he's always there, and I want to thank them as well. Thank you for your attention.
Thank you, Stefaan.
Thank you, Stefaan. This was a great overview, and thanks, Paolo, too. This is phenomenal. In the meantime, we reached 175 participants. Obviously, you can see how interesting this topic is for people in our field. We have a number of questions. I have questions myself, but I can see that there's already a number of questions in the Q&A. Before that, I see there was one, there were a few also in the chat. So we try to use the Q&A for from now on, please, so that we can pose you questions. So I think that one of the first one would be from, I see Miroslava Funakova asks Paolo, thank you very much for a great presentation. I would like to ask, during thoracoscopic aortopexy, do you use selective intubation? Is there a need for insufflation? What kind of stitches, material do you use for pexy? I think you mentioned the Prolene, but Paolo.
Yeah, no, there's no need for selective intubation, and you need to have to have a good sized tube in the sense that sometimes the anesthetists don't tend to put the bigger tube, but you need a good sized tube because we would certainly do a flexible scope through the tube, so a 2.8 or something. So you need a good sized tube to look inside while you do the aortopexy to pull it. And I'm sure it's the same with Stefaan in the sense that they need to have the vision inside while doing the operation, but you don't need to do selective intubation. We prefer the Prolene just because I like very much the needle of the Prolene. But a non-absorbable suture is important. And then, as I was saying, we use pledgets to avoid the stitch to migrate through the bone. But I wanted to challenge Stefaan in a way that I think that Darius' comment in the chat about moving the esophagus from the back of the trachea, it's a very good one in the sense that we use tracheopexy in some of the children. And in some that we've seen benefit is the one that maybe had an esophageal stricture with a very up pouch of the esophagus. And so just moving the esophagus away from the posterior of the trachea, that was very useful. What do you think about that, Stefaan? And I very much enjoy your presentation. Thank you.
Thank you, Paolo. Well, actually, I have a slide of, maybe I can share that. There is an anatomical, see if you can see that. Yeah. I'll try to put a slide in to show you this one. So can you see this? No, okay, there you go. Yeah, this is an anatomical transaction of a normal airway and the esophagus. And if you see that this is the common wall between in a normal patient, so a not patient, like a normal structure, so the common wall. So if you can imagine that if you have a bolus obstruction or a too much dilated proximal pouch, it can also help in intrusion into the lumen. So I agree with that. It does. It could make it worse actually. I think that you should be aware that you move the esophagus to the right side anyway. That's what we do all the time. But you should leave enough room for the esophagus to enter the thoracic inlet. So you can't go up too high into the neck, although you could try, but then you will close down the thoracic inlet, and then the esophagus might be obstructed.
And Stefaan, looking at Dario's comment about the esophagus vein in one of the videos, maybe I didn't see it right, that you showed you made the anastomosis behind the esophagus vein. I was a little surprised why you're choosing this protocol, because one of the reasons to leave it is to prevent refistula also, right? So
yes. Well, it depends on where the insertion of the distal esophagus was actually. So we usually don't take the esophagus vein down anymore. Preferably, you will put the anastomosis, the esophagus vein between the anastomosis and the TE fistula, because it can also prevent a TE fistula from reoccurring, I guess. On the other hand, if you don't have enough length, it's just another extra detour, especially in that case we saw there. So it's, yeah, it just came that way. But we made the suture on top of the esophagus vein, and it's possible. There are some techniques. You have to lift the anastomosis a bit higher up, so you need one extra instrument, but then you can get good exposure of it thoracoscopically.
Great, thanks. There's one more question. Has anybody tried PDS for posterior tracheopexy? Dr. Zales is asking. So a non-permanent suture, a resorbable suture. PDS. Any experience?
For posterior, we use non-absorbable, and I know Boston uses, I think, PDS, I guess. We don't, but I think Boston does, and they do even like a whole suture line, like a mattress suture to it. So they put more sutures in it than we do.
Okay.
Actually, I spoke to Ben once, and he said that nowadays they want to perform posterior tracheopexy in all the children, but they started doing it just to prevent TE fistula recurring by moving the posterior wall away from the anastomosis of the esophagus, and that way they hitch the posterior side also to the vertebral column. As one of the benefits.
Michele Torre from Genoa. Hello, a question for Stefaan. Have you tried to give the tracheopexy stitches after esophageal anastomosis is completed? Leaving the esophagus on the left side and give stitches on the right could be easier.
Yeah, we always keep the esophagus on the right side and not on the left side, because eventually down towards, we operate from the right side, so we also distal esophagus is also on the right side. I know a patient also from Italy who had like the upper part on the left side, then crossing over towards the right side with the tracheopexy, and yeah, it's like a chicane. Like it goes like from left to right. So we started. Well, we always perform the anastomosis of the esophagus on the right side and keep the esophagus always on the right side, leaving a direct plane for the tracheal stitches.
a few questions around really the bronchoscopy, tracheoscopy at the beginning. Stefan, you mentioned that survey done 10 years ago, where in fact only a smaller proportion of surgeons would do a bronchoscopy. And then I think I read at some point in the chat and Q&A from Ronnie's Fire from France that in fact there are some centers that don't do it because they don't have a ENT surgeons. And Darius here says we do bronchoscopy ourselves. How do you stand? I mean, what do you guys do? I think for me, my practice, I always do. This is how I've been thought. It's very important that you get a lot of information well beyond the tracheomalacia that maybe is not that relevant on day one of life.
Yeah, I mean, we're very fortunate in the sense that ENT have a rota, and they will come in for any esophageal atresia. So we used to do, as you know, Augusto, we used to do it ourselves. But it's some of the surgeons were not happy to do so, and so we discussed it with the ENT and given more of a baseline equal to everyone. The ENT will always do the MLB. But before, there would not be esophageal atresia going without an MLB. I mean, in some premature baby that are already intubated, we will still do a flexible. We'll not do a formal MLB because of the risk, of course, but the MLB will always be, yeah, I don't know, Stefan.
Yeah, actually, we have been performing that since 2012 in every patient, unless the patient was not fit for it or too small, or there are other reasons. But it's a standard procedure. I think is very important. It's seeing the tracheomalacia. It's also seeing the proximal fistula or excluding it. Actually, I think over 40% of the long gap type A and B patients also have a proximal fistula, which you're going to miss. And also carina fistulas, like if the fistula inserts in the carina, and then you will face long gap patients, like type C long gap, I don't know. We're working on to study how our patients do there as well. And also understanding tracheomalacia, you need to look into the airway and see what comes from it, and we need more data on it. And I think, I'm very happy to work in an airway and like esophageal and airway team center. And I think if you treat esophageal diseases, you should always consider that the airways are part of that spectrum. So I think. And I know, Augusto, you said that in your 2014, 43% of respondents said they perform EA with after bronchoscopy, EA surgery. So it's not a lot actually. So that should improve definitely, in my opinion. I hope it's improved.
I hope it's improved. There's a couple of other points just for, I think, educational purposes. So one is, of course, and that's where the ENT surgeons are in a way helpful if there's a cleft. So they also can grade the cleft, and they're the ones who will then fix the cleft a few months later. But there's also something that I've had in a couple of patients, which is a PIC bronchus. So an additional bronchus that it's nice to know before you open the chest or if you do thoracoscopy, just to know your anatomy. So that's why I think we should do.
Augusto, just for what it's worth, Dario said we do the bronchoscopy yourselves. I think it's great if you have the ENT and pulmonologist involved. I just put one link in the chat. But there are situations where nobody's around or they fall short on personnel and nobody can come to the OR. There's actually a nice single-use bronchoscopes from Ambu. And they're like €250 per bronchoscope, and you do not need any cleaning of those, and you can just have them stat, and the image quality is really great, but you need like a 3.5 ET tube to go through that, travel through that ET tube. But if you have to do that, every surgeon is talented enough to use that bronchoscope, and the image quality is really great, like to observe the stitches when you do that tracheopexy. whether they do not interluminal or not. The image quality is really much better than in an old bronchoscope that is like written out with all the fibers broken. So just do what it's worth.
Yeah, no, I would agree with that, Martin. We use it as well. The problem is single use. So
yes, it's environmentally is not a good idea.
Yeah, but I agree.
It's not very green environmentally.
Yeah, but all the washing of the endoscopes, we don't know what happens there, right? Which solutions?
Yeah, the other thing, reflecting on what Augusto say, I would aware people to be, you know, really don't trust the initial MLB for everything, in the sense that, you know, cleft in little babies can easily be missed, and you may need more than one MLB. Same thing for an upper fistula. I mean, that sometimes is difficult to recognize and difficult to diagnose. So if you have symptoms, please redo an MLB, because sometimes can be difficult to diagnose. So it's very important to do it, but don't rely on all the information, tick the box and say, that's it. If the symptoms of the child are associated to any cleft or upper fistula, it's very important to redo the MLB, and it's never a waste, but it's a good point.
It's a question about primary tracheopexy. If this can be considered if an aberrant subclavian vein, artery, is seen during the operation.
Well, yeah, I think if you see, there are many of these children have anomalies of the arteries as well, cardiovascular anomalies. If you encounter that, then you would try to prevent. Of course, you won't do any stitches which might damage or injure any artery. These children usually will have a CT scan, and then maybe they're more fit for a heart surgery. But usually, of course, they have a preoperative full cardiac workup, and if there's any suspicion of a vascular anomaly, then we will treat it accordingly. Also, if they need open heart surgery, that's some contraindication to perform aortopexy, of course. So then we would combine that with that open heart surgery. So we don't perform, then we would leave that to the cardiothoracic surgeons.
Okay, then next question is from Caroline Party, asking about overtreatment of the technique Stefaan suggested. So she argues that the tracheomalacia usually improves over time, and does doing a primary posterior tracheopexy at the time of the repair is not overtreating those patients.
Yeah, I think that's a question which we don't really know, but we do know is that the morbidity in the respiratory tract infections in these children, if you look closely and you start recording it in a multidisciplinary team, you're going to find that like over 40% of the children have severe respiratory tract infection. And if you look at end-stage pulmonary disease in adults, over 25% have that. Because of the recurrent respiratory tract infection and malfunction of their airways. I think there's still, we underscore the respiratory morbidity in these children while growing up and adults. And of course, we don't know the long-term results yet because we only have been doing it for 8 years now. So that remains to be seen, but hopefully we can improve on that. It is something also why we perform the prospective randomized control trial now, because there's definitely need to see if children benefit. But if you look at over 50 papers, all do better. Look at the Boston paper just recently. There's a dramatic improvement of their respiratory outcome in these children once they had that. So I think there's a growing body of evidence that you do less harm by performing sutures than you have more positive effect of it.
Another question is on the post-operative course of esophageal tissue repair. Is prolonged intubation and difficulty to extubate an indication for repeat bronchoscopy, looking for tracheomalacia or tracheobronchomalacia? If so, what's the time threshold for doing this?
After aortopexy or tracheopexy?
I think in general, I think it didn't specify.
Well, actually, we looked at our last 130 cases, and children don't do worse in any complication or anything, but we need to look at it in more detail. Reintubation or anything, that's all similar in groups, whether they had posterior tracheopexy or not. Esophageal leakage, all, but we didn't look in detail yet. I don't think it has any consequence on the operation itself. And if you look at secondary surgery, we have children come from abroad, for instance. They usually, if the surgery goes well, then they recover within 2 days, 2 or 3 days, and they can start drinking again, and they're good.
And as a segue of that, Stefaan, do you do follow-up bronchoscopy? This is a question from Anastasia Almond from Israel. And do you have granulation tissue inside the trachea? And if so, how do you manage that? Do you do bronchoscopy as a follow-up?
No, we don't do standard bronchoscopy but we do have a respiratory follow-up for these children. Unfortunately, some of them are from abroad, so we miss some of the severe cases. Long-term follow-up, we should work on that. But we don't have a standard bronchoscopy, but we would, well, we have the ENTs available, and they're partnering up with them. So if we need, for instance, have a dilatation of the esophagus, we would also sometimes look in the airway. But usually they do quite well respiratory-wise, and we will not go to surgery for standard repeat bronchoscopy. I know some centers do.
So Stefaan, may I ask you this question? We do a lot of bronchoscopies on follow-up for a second opinion. Then we see a lot of patients have very long former pouches. So we come from the tracheal side and we see there's a long pouch that has been left. Do you consider this a problem? And when do you think the pouch is too long, and what do you do about it?
Well, we would perform a CT scan to see if there's also vascular compression. And I think, as Paolo said, you need to tailor your diagnostics towards what kind of treatment you want to do. I think nowadays we try to go as high up as possible, but maybe too high, to take down the T fistula. So, but if you look at the CT scan, sometimes you see like a remnant there, or diverticula there, which can cause all the obstruction. And if you don't take that away, then the child will suffer. So I don't think the pouch itself is a problem. It's always described on the CT scan, or people see that. But usually it's not so much of a problem if it's open towards the airway and not a diverticula, like a cyst.
Yeah, no, I agree with Stefaan. I mean, we had a few in which we had proceed with the posterior tracheopexy, and in those, if we would proceed for the posterior tracheopexy and there was a pouch, that is mainly done by Mr. Mutialo. Nagarajan Mutialo is the cardiothoracic surgeon. We work together in the team, and he would also resect that pouch at the same time and take it as a first stitch to put at the pexy.
Yes, that makes sense. You can also staple it across, yeah. Mm-hmm.
You can staple it away. I know Boston, they go way up into the tracheal wall to take it down.
Do you need a fourth trocar, Paolo, for the?
No,
actually, it was for the posterior tracheopexy, so I guess it's
so it's Stefaan.
Stefaan, sorry.
Actually, we use 4 trocars nowadays, because we use one trocar either to pull the lung aside or to move the esophagus away from the posterior tracheal wall, and you lay the esophagus or partly also on the lung, so you gain more access. And also we use it to lift the esophagus from its bed with a rubber band, so that you get clear view and you can still ventilate the lung. You lift the esophagus while dissecting it out of the bed. Yeah, this is all like normal type C surgery. And then in performing the anastomosis, we use the fourth trocar sometimes to lift the suture and therefore turning the anastomosed esophageal pouches towards you, so you can place sutures on a 90-degree angle. Yeah, we have actually now we have standard four trocars, 4 ports in. Yeah, three working ports. And also, especially if you have a long distance, it's easier to get access towards the thoracic inlet, but also moving down towards the diaphragm. Yeah, we used actually to have no. We used to have no very low pressures, and we just push the lung away a little bit so we can have room to maneuver as well.
So Stefaan, can I add that question? You said in your presentation it takes quite some time until you see this picture, and there was the not primary tracheopexy, but the one where you go in later. In my experience, is as you described, because there was a really honest video. It's very hard to find the plane between the esophagus and the trachea, and you showed one video where you even made a hole in the trachea, which can happen. And my question for you is like, are there any tips and tricks how you separate the esophagus from the trachea? Because that's, I think, really very, very hard. And the second question is, have you ever encountered problem with dysmotility? We had a patient where we did that, and after that, the trachea was fixed, no tracheomalacia, but now the esophagus is very dysmotile, even more dysmotile than it was before the operation. Then you trade one problem for the other.
Well, yeah, I think also in TE fistulas, or high proximal TE fistulas nowadays, we use a stapler for that because it's. But you need to get access above the TE fistula, and also here you saw the hole. Actually, it was not in the video, but the wall was. Yeah, of course, it was the material of the wall was quite thick actually. So we placed the stapler on it, and then it was sealed both ways. It's also the esophageal pouch was too broad there, and stapled and esophageal wall. And we didn't see any dysmotility in that child. And yeah, I think I showed the video. Just I have better videos which look brilliant, but it's just to say that performing it can be very cumbersome and very difficult, and it takes sometimes hours of meticulous surgery, and you will have lung damage and all. It can be very difficult.
I'm glad you showed an honest video and not the perfect one. Otherwise, it looks easy.
Yeah.
Okay. There's a question from Dr. Jury asking differences for post-op complications. Esophageal stenosis in patients where you did the posterior tracheopexy.
Yeah, actually, because I knew this, we checked. We checked many factors, and so far, but we didn't look in detail yet. We did a statistics on it, and nothing is different. Actually, they're really similar in both groups, like leakage, oral feeding, respiratory tract infection the first year. It's just, I don't have the details of that yet. But also in the cohort we already published, the post-operative complications were similar in both groups. Maybe we had some more stenosis in the esophageal, in the tracheopexy in that group, but in the larger cohort, we didn't see that yet. Refractory stenosis. It was actually lower in the tracheopexy group, but very limited numbers.
There's another question from Dr. Amol. Question for everyone. What is your opinion and experience for additional distal aortopexy in case of bronchiomalacia during posterior tracheopexy?
So we have when we fail. So in our flow chart, when we fail aortopexy, we would proceed with the posterior tracheopexy, and that will be done open and together with Mr. Mutialu, and we would so we will do through a limited sternotomy, and then taking down the previous stitches from the aortopexy, going on the back, fixing the tracheopexy from there, which is done by a cardiothoracic surgeon, of course. And then on the way back, we will redo the stitches of the aortopexy. So we will do the two together in that contest. So that's where we use the both, if it makes sense.
Yeah, I think it's part of the armature. You need to also have both available, I guess. So there are patients who will need both, and or even combination with cardiac surgery, for instance. So yeah, you need a good plan preoperatively. So a CT scan and a multidisciplinary approach, I guess, is very important in these children.
There's a point again of Mike.
Yeah, I'm just looking through the chat also, because there have been people in the chat also with questions.
There's one on from Ronnie's Fire. ENT are mandatory for laryngotracheal associated malformation disc. The diagnosis and treatment. So, for instance, for low-grade diastema, that can be corrected in the same procedure, assessing the malacia and to be proximal fistula if possible. Yeah, for sure they are in the trachea all the time, and not everyone has an ENT, a pediatric ENT. Not every center has that. I think we all work in centers where we have those.
I would also add one of the benefits. I would also add one of the benefit of what Ronnie is saying is that when the ENT do the initial MLB, we use either the spaghetti, the suction tube that they use, or a very small NG tube to decompress the stomach. So when you put them supine for the thoracoscopic esophageal atresia repair, that the anesthetists are very happy. So that's another little trick that the MLB can get you to. I don't know if Stefan's used the same, but it's certainly very
good. Definitely. Also, they're across the hall here, and we work together every day. And so we enjoy each other's company in that way, that we try to look for the best approach in every child. Also, one of the things we in children with severe reflux and BPD, for instance, and damage to the lungs, and they can't be operated. Then we place a balloon, usually from below, actually through a gastrostomy, in the distal esophagus, together with the ENT, over a guide wire, which is brought from above, to block the distal esophagus and to block reflux in the lungs and to stabilize a child with severe reflux into the lungs at that time. So we won't ligate the distal esophagus. First, we would place a balloon in the distal lumen, and therefore we need ENTs, because you need to do endoscopy from both sides, actually, and fluoroscopy.
Of course, we're talking about complex patients who need, this is not a bread and butter TF patient, but I would say that if you don't have pediatric ENT surgeons in your center, still that patient should be scoped before the fistula repair before. So that, in that case, it will be the surgeons, the general surgeons. It opens up, of course, another conversation about centralization, but obviously every country is different, and the beauty of these webinars is that they really go beyond the boundaries of the borders of Europe. We have people from really all over the world, all 5 continents, and of course practice, pediatric surgical practice is different everywhere.
There's one question in the chat on proximal bronchomalacia and in general bronchomalacia. So you mentioned both in your talks that bronchomalacia is a problem and is not maybe treated with the techniques you suggested. So what do you do in severe bronchomalacia? Yeah.
I don't have much experience in that, actually. So I can't tell. I think it's pulmonary artery compression on the left bronchus, for instance. But yeah, so I didn't encounter too many patients with that in EA patients. I know, Paolo, you had more in your series, I know.
Yeah, so we would it would be another different flow chart in a way, but we would use stent inside and outside. So with splint and stent essentially. So stent inside, which are a temporary maneuver. Those are patients that may fail and very often fail. And in a splint from outside, similar to the experience that Cincinnati, for example, reported, which you can stitch even a Gore-Tex may work, or you can have 3D printed type of splint from outside that you can stitch your bronchi to. And that is, of course, is a complex surgery that we do with our cardiothoracic team. But sometimes you need to do a tracheostomy. The tracheostomy is still a very safe maneuver to do in children that have severe tracheobroncho and do not respond to more or less invasive treatment. So, there are patients that fail those treatments that we're discussing today, and you shouldn't exclude completely the tracheopexy, because I think there's also one of the answer about ALTE. Certainly, we would investigate with pH impedance and so on, but the ALTE is a severe event, which, if it happens twice, it may lead to death. And so you need to be very serious and very careful when a patient has one of these severe events at home, and not to under-evaluate. So certainly you need to make sure that you're not missing something else, but it's a severe thing. And as said, you may have to do something very invasive in some children.
Do you call them altis, blue spells, or bruise? What's your preference?
I think bruise is the more terminology that is used more frequently. I'm probably have a bit of white hair, so I'm used the old one, Alte. But yeah.
Yeah, it's unexplained in it, and I don't think it's unexplained, because we were talking about what the reasons are why these children have these symptoms. So it doesn't feel right to me a little bit. Bruise. Right.
Yeah.
There's one question or several questions about optimal timing. So which is the ideal age, weight for these procedures?
So the optimal timing is first time right, I think. Once you're there, do the right thing, I guess. So but it needs to be seen. But I think, I think the best time is when you're there the first time, I guess. But if you have to go back, it's very difficult to choose the best timing for redo posterior tracheopexy. Usually these children are a bit older, have suffered a lot. You need especially take care of their pulmonary function and their have them in an anabolic condition to undergo this type of major surgery.
Yeah, I mean, from our side, the aortopexy will not be taken in consideration in the first couple of months of life. I mean, usually the symptoms appear a bit later. These are a bit of older children, but nevertheless, it's done earlier on in life. So we would normally have it certainly in the first 6 to 8 months of life, also because the trachea then, if you have gone safe until then the trachea start becoming a bit more rigid and a bit safer.
One thing to consider is that it's not only tracheal cartilage weakness or posterior intrusion, it's also reflux, it's also esophageal dysfunction, it's also aspiration, it's many things, colonization, because half of these kids are colonized with bacteria in their lungs, for instance, which we now know. So you have to look at it in a very multidisciplinary approach, and for instance, start feeding beyond stomach to get the patient in a better nutritional status, for instance. Look for reflux, look for stenosis in the esophagus, which might also cause obstruction. So it should be multidisciplinary.
There's one question about the robot. Do you think this surgery would be easier and safer with a robot? From Tunis.
Well, for the aortopexy, I don't think the robot that is available now at that age is feasible in terms of space. I know there's being experience in older children with a robot, and I believe also with the tracheopexy. But we are talking about a different population, I think, on older children.
Yeah, I think that the robots are definitely future for minimally invasive surgery, especially also in neonates. But at this time, the techniques are not, they're not small enough, the instruments for our population. And then you try to maneuver around that by, for instance, putting the needle hole in your left hand, if you have the suture on the left-hand side, for instance, or placing trocars wisely, or an extra trocar to make another angle, for instance. But working with robots on population is something that's going to be the future. I'm quite sure.
Just for what it's worth, I just put one paper in the chat. It's a Chinese paper on 155 robotic TF repairs in the neonatal age. So I think that's one of my favorite papers where the future could be.
I think on these notes we can stop, because otherwise we can continue forever, and it's like already almost an hour and a half. I will try to share something that is not really directly related to tracheomalacia, but let me see if you can see my screen. This is a survey that is run by EUPSA. Can you see?
Yes.
Okay, I don't know. This is a EUPSA survey on gastrostomy insertion techniques. You can see that there's a QR code. You can scan that, and obviously this is again a EUPSA related activity. Nigel Hall and his group in the network office are launching this, or have launched this already some time ago, and they're looking for more participants. So if you haven't filled out this survey, it's definitely worth it. I can imagine that people that are listening today to this topic are also either putting gastrostomies themselves or anyway involved with patients that might require gastrostomies, and so it will be relevant for them. Okay, Martin.
Yeah, I think we tried to cover all the questions that you post in the chat and Q&A. I hope we did not miss them out. Yeah, thanks for all your active participation. I think this was like one of the best EUPSA webinars we had so far, both in terms of quality of the presentation and also number of delegates watching. So within the next days, we will edit this webinar, then put it on our YouTube channel. For those who are not followers, you can go to YouTube or type in on Google EUPSA YouTube channel, and all our webinars are placed there, and you can digest that kind of educational activity at some lecture time point if you want to. Yeah, that is it from my side. Also, thank you, Stefaan.
Thank you very much.
Paolo, Augusto. Always
thanks, everyone.
And of course, Gaia for promoting all these activities on EUPSA social media. And yeah, see you next time.